Hello, everybody. Hi, Katie.
Sarah, nice to see you.
Nice to see you too.
I don't know if it's the lighting or if it is because it's 4 o'clock in November in Vermont. You've got some like golden lighting going on. It's quite
Oh,
lovely.
it is 100% golden light.
Yeah.
It is gorgeous here. It's a gorgeous day. I had a little bit of time off, which I don't usually have during the day. So I felt like I needed to like walk out in my cute little city and just feel all the love.
Yeah.
You know, get like a local chai, and like say hi to my friends at so it was just resplendent here today. Just,
I love that.
yeah. Yeah, and the cute little hippie coffee shop that's been here forever. All these
What
things.
coffee shop do you like?
Muddy Waters.
Oh, classic. Okay.
Like I'm like way back throwback. For anyone who's not understanding what Katie and I are saying, there's a certain era of building in Vermont, which is akin to like Bolinas, California, or like, old hippie towns in Oregon, where it's like 100% hippie crafted in 1970 or 60s. And it's all like natural wood and plants and like art and like housing justice posters and like it's like literally like it's still the same way it ever was. And so I was like, I need a chai from Muddy Waters. Nothing new or different about that place. It's just always good. Welcome again. Sorry, now I'm going to start the business. It's been a long week. Welcome to the Gravity Public Call. We have a lot of wonderful content to present with you all today. This is, there's been a lot of significant movement in the coding for food world, and we welcome all of you. And then there's some updates on the program classification as well. We'll kick off the call November 7th. Here we go. Next slide. I'm Sarah DeSilvi, the Director of Terminology. If you want to put who you are and where you hail from in the chat, that would be helpful just for note taking. We're glad you all are here. We do mute individuals upon entry. All calls are recorded. Recordings are going to be available on the Gravity Confluence page. And you're like, please send questions to everybody. I tend to read everything out loud. So just know that if it's in the chat, it's part of the call, just because I try to facilitate a seminar-like format, even if people are just writing things down. Next slide. We, as a standards development entity, have a requirement to comply with federal and state antitrust laws. And we're really, generous about applying these. So it's not just direct antitrust violations, but anything that might be construed it. So we just try to keep it on the up and up here within our work in standards development. Next slide. So here we're going to go through an end-to-end review of coding for food concepts. We have a few more meetings, but we're heading towards the vote for the consensus vote on November 21st, which is off cycle because of the Thanksgiving holiday. We are then going to go into program classification updates. We have a few. We just worked through a really complicated domain, and we're now getting into health concepts, and we have a few more. We've increased our frequency there, so we're going to be updating the master more regularly, I imagine, as we increase the frequency there. And then I have some updates from our program term analysis as well on our partnership that we're working on with CDC. And then we'll do homework and next steps. Next slide. Announcements. The first one is the same one as it ever is. Next slide. No updates here. It is still open for comments on our IC10 submission for utility and security. We are still meeting in our technical work stream every other week from 1 to 2 on Wednesdays. We have one more implementation affinity meeting. We're working on the topic there for that meeting. We just had a meeting last week on Halloween with NCQA as a guest. So our last implementation affinity meeting is November 21st, topic to be determined. Next slide. I wanted to do this community announcement. Welcome all friends and guests to the meeting. As many of you or some of you know, I have the humble, surprising honor of being the co-chair of the country's Health Information Technical Advisory Committee, which is the committee that determines recommends health IT standards and policies to the federal government. So we just kicked off with a new Health Equity by Design task force. The purpose of the task force is to provide the Assistant Secretary of Technology Policy, the entity formerly known as the Office of the National Coordinator, with recommendations on promising practices, challenges, and resources to support health and human services organizations to incorporate health equity by design principles into the design, build, implementation, and use and monitoring of health IT. This is our accountability as HITAC to ensuring that we leverage health equity by design, that we actually define what we mean by when we say health equity by design and really guide and support ASTP and recommending guidance to integrate into regulations and policies and standards. The meetings are public and we welcome you all to come. I do want to note that there's many HITAC members on that committee, but there's also lots of Gravity friends. So we welcome you to those meetings if you want to participate. The calendar and the links are in the chat. Just grateful ASTP is focusing on this and grateful for all the Gravity friends who are part of that work. Next slide. Any questions on the announcements? It's nice to see some new friends here. It's really, we want to, this is an open consensus place, so welcome, and we have some pretty fun things to discuss today. Next slide. All right, so just a brief update on what is Gravity Project. Gravity is a collaborative initiative with the goal to develop consensus-driven data standards to support the collection, use, and exchange of data to address the social determinants of health. Next slide. We have a lot of amazing sponsors that help us do what we do. We have sponsors that submit, resources, like in-kind resources or monetary resources to support our work. We also have, again, I say this every time, but it's actually really important. We are unique in the HL7 accelerator world in that from a social justice model, we ensure that direct care entities, community-based organizations, and patients have equal representation in our governance. So very, very grateful for that model and how we execute it, and for our patient and CBO entities, community-based organization entities who help us do what we do. Next slide. This is our 2024 roadmap. We are almost through. So we are closing down our 2024 public terminology cycle across these two areas of work, enhancements, and our two domains of reference, language barriers and incarceration status. We have some upcoming releases of information regarding our payment and reporting discovery, and we are working on our technical work stream on our STU ballot aligned with US Core 6.1. And we have our final implementation affinity group, as I mentioned. On the bottom line, I'm sure many of you know, but our focus for the last part of the implementation affinity group has really been to create webinars of sorts on critical questions that we get from Gravity to support implementation and allow those affinity meetings to serve in our library, our implementation library. So if you have some questions regarding implementation, everything from tips and tricks to implementing terms to like how we conceptualize outcomes to you name it, there's all kinds of topics we've addressed over the course of 2024 in that implementation affinity group, and they're all collated in a library in our resources for implementation section. So lots of good material there. Again, that's been our focus on 2024. Next slide. Last summer, we were honored to participate in really like a kind of groundbreaking and visionary effort, which fully centered the voice of our social care friends. Right, I talked about how our model includes social care voices as part of our governance. But that's more senatorial, like they get equal votes, they get seats at the table. So we just sat in a sea of wisdom on social care last summer, and you're going to see it's informed pretty much almost everything that we do over the course of 2024 and looking into 2025. So all kinds of exciting things happened from that. The report is pretty interesting. You can see it referenced all across different standards work now and different, not even just within gravity. And you'll see little icons. What I'm trying to do, if we could look at the next slide, is whenever we're talking about our work, drop those icons just so you can see how we are accountable to the domains of the use cases and concepts that our social care voice friends elevated. I'm sure you're all aware now that 2025, our new domains are person level concepts and discrimination. So it's a week, so I'm having like a moment. Chronic stress, which is the cumulative effect of many different social and structural stressors, not just discrimination, but since every core measure of chronic stress does include person level discrimination, we're coupling them. And then in the fall, we're working on food access and neighborhood safety. And then we're going to continue to have this meeting where we're having not new domains, because we can't put it all in one meeting, but enhancements. Continue to work with our friend, Katie, and the team for the Coding for Food work on the remaining concepts and continue partnering with CDC. I'm really hoping to lean into terminology to support protective factors. Again, the hopeful asset list to balance your problem list in 2025. Next slide. Okay, here we are. One more meeting before the vote, and I think you're going to see there's a lot of new content. And again, I've really tried to make sure as many of the SMEs in those work groups came today. I really want you to feel like we have a discussion today. It's the major topic. There's a little on classification at the end and some CDC updates, but most of the time we're going to be focusing on coding for food over the course of the next slides. And then we'll talk about the process for the vote as well, so everyone's informed. Any questions? All right, we're doing great on time. Okay, next slide and next slide. How you can find, I think for the first time, we actually are going to have something more than the slides when we post the masters, because we have I can make a document out of what we have now. So on Tuesday, when you go to download the masters on Tuesday afternoon, what you see on the slides should be transferable into like a one-pager that you can download and spread around. And then all of our other work is happening. The classification will be posted as well. I just did my homework. I promised my classification friends I'd finish the gravity component, and I did a rough bit of it, and then I want to keep on going this over the course of tonight and tomorrow. But we'll have all the masters associated with this work and this meeting posted on Tuesday evening. Next slide. All right. We know what end-to-end review is. I'm going to say it one more time. Well, some of us do. I want to acknowledge that there's some new people, and I have to admit I got distracted there for a second because I saw my friend Julian's on the call. Hello, Julian. Congratulations on your new job. It's hard. Like those of us who've been doing this work for some time, it's like a little, it's like a community within a community. So I just wanted to give props to my friend Julian. If there's anybody new, I am going to run through the end-to-end review approach. End-to-end review is a time to step back and consider the whole set of information that we have and ask questions. Is there something missing? Like in the descriptions and service descriptions that we're creating, is there something missing? Or in the classification, is there something missing? Are there incorrect concepts that need to be changed? Just something like not right. And that's a lot of what we're doing right now is just tweaking, like leaning in deeply to the subtleties of things within coding for food and tweaking. Or, within classification, I'm going to give a different version of this. It's like changing, changing naming or wording. Hi, Julian. And then we do ask at this phase if you have anything, it'd be complete, submitted in written form. And we really want to encourage you to disseminate, right? Like we're doing really critical stuff here. send it around. We have, as we'll mention, an amazing advisory committee, incredibly robust entities who within each of our work groups. And I want to note, just for everyone's comfort, there was a question within our steering committee on whether or not we had sufficient representation from end users, direct care entities. I'm like, it's just them. Everyone in our work group is deeply involved in actually doing this work. Oh, thank you, Julian. Yay. Everyone who's in the work groups is deeply involved in actually doing this work. And so we have very practical, pragmatic questions, right? Like, we are all operations supporting the work that community-based organizations do and delivering the coding for food services. So I just want to note that practical is the base, thanks to the amazing work that Katie and Kristen did in collating work group experts. Just a reminder that any element, any comment you have has to be reviewed by our subject matter experts before it goes in. So far, most of the comments we've received are already things that that are in process, so it's good. Next slide. All right, consensus voting is what happens next on the 21st, and we wanted, because some of you are really coming to the community of gravity specifically for the coding for food purpose, we wanted to spend some time making sure everyone understands how the vote goes, right? The voting is going to occur on a Google poll during the 11/21 meeting. So when you're going to, on Tuesday, you're going to download what we have, right? You're going to submit end-to-end comments. You're going to submit end-to-end review comments if you have them to gravity@hl7.org. Right? Our work groups are going to meet a couple more times. It's weird because, again, Thanksgiving holiday, we have a weird cadence. We're gonna, we have one more meeting, I think. I'm just trying to, we don't, I mean, it's been a week, my apologies. So then we will reconvene and have the vote. And then the way the vote, because the work groups are going to integrate whatever comments you have and then present a final product. The way voting occurs is via a Google poll during the 11/21 meeting. And these are our standards for what voting means, because the expectation is we work in consensus and community. There are a million pathways to offering insight, as you all should feel. And if you're not, please let me know. If you don't feel like your voice is being part of this process, I'll happily ensure that we include it. But the idea is then there's a formal way that we vote respecting this process we've all been in together, right? So a yes vote doesn't necessarily, and so there's a yes with comment, formal objection, or abstain. A yes vote doesn't mean that the deliverable is the ideal one from whoever it might be, but it's better to move forward than block the deliverable. Yes with comment is the comments are usually addressed in future revisions of the deliverable if that's necessary. Any formal objection has to include a comment. Again, yes with comment and formal objection both require an email, because it's like respecting the consensus work of the group and the work of all the subject matter experts. It's like, if you have something to say, you have to submit it formally. Formal objection is the vote has to include comments indicating a path to address the objection in a way that meets the known concerns of other participants in the project, right? Because we've done this work together, our subject matter experts have put in a ton of hours, right? So like a 11th hour, like monkey wrench is it's just hard. So we try to make sure that if you're offering a comment, it integrates the perspective of the group, and then you can of course abstain. And if you don't offer a comment, a formal objection just switches to an abstain. It sounds complicated, but if you come to the meeting, it's definitely not. If you're not able to come to the meeting, you can request an absentee ballot just by emailing gravityproject@hl7.org. So this is how the vote happens, and then so we'll come back, post the end-to-end the master on Tuesday. A few little tweaks, but there's just some little things that we're working on right now. And then come back here and meet again on the 21st for the vote. Any questions on the vote process? We wanted to get in front of you all early because some of you are new to our work.
Sarah,
Okay. Hi, Lucy.
hi everybody. Can I
Or
just
not Lucy, our work.
confirm, can I just confirm that once this group approves, this becomes, shall we say, official gravity policy, so that any outside entity interested in our standards can take what we approve, assuming we do, as our definitive word, at least for the moment, on this domain.
100%. That's why. And this is the great thing about this meeting is that like everyone can come to it, right? And we do our yes, absolutely, Lucy. That is true.
Okay,
Yes, and that's
that's for people who may not have been in on our calls or our process
yeah.
forever, but I just wanted to hear you say that, and it's reassuring. Thank you.
Yes, and there's, sometimes, Lucy, and you're aware of this from a couple of our domains, we also vote on like artifacts that are not the codes or concepts. I'm saying that because we're gonna likely have two different kinds of artifacts that we might talk about on the 21st that are not here yet. I'm gonna like one is, a statement of support for RDN reimbursement given how difficult it is to pay for registered dietitian nutritionists in current healthcare policy. We've talked about this concept in this meeting a lot. Our friends at the Academy of Nutrition and Dietetics are drafting a brief on that. And so that if that's back to us in time, that will also be something we say gravity stamp, not a formal vote, but just like it's brought to the meeting, we talk about it, and then it goes up to the operating committee. And then another thing that we've, again, in the incarceration status domain, again, this is not a data artifact. We have a statement on, yay, Denise. And then another thing is it's not a data artifact, is our statement on screening and bias and incarceration status, right? We've had very consistent statements on how to use data to minimize risk and support individuals in getting access to services and their journey to wellness. And so that, our SMEs for incarceration status are working on a one pager on that as well. So it's both the data but also we're trying to do a better job of creating like knowledge artifacts as well. And I know you know that. I'm just saying that out loud. Because this convening doesn't always just create like a HCPC code. It creates transparency to inequities or best practices, and we try to elevate those as well.
I think the concept of knowledge artifacts, I haven't heard you use that term before. Maybe I haven't been listening, but I think that's really interesting. And again, I would raise the question for knowledge artifacts, perhaps developed by other entities that we've worked with or you
Yeah,
approve of or whatever. Does the operating committee approve those? So somebody looking up a particular domain on our page can discover not only our standards, but these knowledge artifacts as
that's
some
my hope,
official.
Lucy. Yeah, that's my hope.
Okay.
Yeah, and you're a member of the operating committee, so that's my hope. And
Actually, I'm
oh, you're
not,
steering.
I'm steering.
Okay.
So we could talk about who's in charge here and who should be approving things, but I won't divert us with that
Okay.
conversation right
Okay,
now. Thank you.
I'll talk to you offline. Okay. Okay, regardless, we create lots of knowledge, and that should be an artifact as well. Okay. Okay, I think for any questions on voting. Thank you, Lucy, for being an ever engaged and amazing person. I did get the pharmacy thing, by the way. Amazing. More on that next week. Okay, no questions. We're not going to move into content. There's a lot of content today. Okay, next slide. Okay, here we go. If you want an absentee ballot, send an email and we'll get you on. N10 review for coding for food. Here we go. So there's a lot. This is a slide that hasn't changed. There's a confluence. It has the kickoff. These are the three concepts we started with. And it's all under the food insecurity because it's enhancement of that work, even though the concepts we're talking about are not just solely linked to food insecurity, because the evidence for food medicine goes beyond food insecurity. And there's a lot of, we have a lot of conversations regarding that. Okay, next slide. Just again, thanking our dear friends we are, I'm calling you a national foodist medicine leader, Katie Ettman, which is what you are, right? Partners across a partnership to align social care, amazing subject matter experts, and the goal is to submit for a new HICPIC concept to MIRIS in December, which we are well on target to do. Next slide. Just a nod, you know, this is one of the amazing things about this work. It was so long in the planning that when people write me an email and they say, I'm worried that X isn't involved in this work, I can say, oh, but they are, right? Because the amazing advisory committee worked fearlessly on this effort. Even members were trying to, like, a member was like, I really feel like my food insecurity expert needs to be on part of this work. And I'm like, oh, they already are. So just know we're incredibly grateful for our longstanding friends in the ecosystem who are part of the Coding for Food Advisory Committee. And next slide. And again, just grateful for all of our SMEs who put up just tireless hours. And I think we corrected the naming problem on the slides. I think so.
Yes, we did.
Okay. Yes, thank you. I saw the comment. I saw the resolution. I was walking and I was like, go team. Okay, next slide. Again, this is what exists. It's really important to think about this because what exists defines what we will get in some sense if we can't defend how what we want is different, right? It's a real clear need when you're submitting a HICPIC concept is to represent why it's not sufficiently covered by the codes in the ecosystem, right? So these codes were not going away. So when we think about our concepts, we have to lean into that. Next slide. All right, so this is not a change slide, and there's going to be a series of, I wanted to use this opportunity to bring anybody who's not a food insecurity expert or anybody who's trying to figure out what are they doing in their work groups to bring you all along with us. So even though we talk about cost, we're not allowed to nor drive the service on cost alone. And so we've had a lot of conversation on what is the dose of this? Like how much are we supporting? But we're going to go nerdily, and I'm going to show you this call out that the good thing about that is the USDA has so many materials to support crosswalks between recommended servings or cup equivalents and cost. And so even if some of our services are providing the exact thing, and some of our services are providing like a card to go and purchase the thing, we can represent a standard by using the conversions of the USDA. More on that in a second. We're not focusing on duration, even though duration is evidence-based, and we are focusing on individual level service provision, even though it can be multiplied for households or certainly shared by households. We are focusing just on the 1%. Again, this is not new. Next slide. And there's so many SMEs work group people on this call. Feel free to if I didn't represent something well, let me know. If you have insight, please bring it to fore. And I really want to make sure that we're using this moment as a conversation piece. So every slide, if there's something that you don't feel like if there's an opportunity to add value with what you want to say, please say it, right? I mentioned this early, but even though some of our concepts are bound to by a value statement and by a differentiating statement to the labor of registered dietitian and nutritionists, what we know is that we can't package them both into the same concept. We have to talk about the thing that we're offering, for example, medically tailored meals. And we can mention that it requires the labor of an RDN, but the exact labor of the RDN specifically is billed for separately. Our colleagues at the American, and there's a lot of complexities in what medical nutrition therapy, which is the what is happening. There's a lot of complexities in reimbursement for that. And I just mentioned those early. So our friends at the Academy of Nutrition and Dietetics are crafting a brief, like a one-pager, on how that labor is critical for, specifically like Medicaid supported and other payer supported food as medicine initiatives, and how the changes to policy would best support that in implementation. Because right now it's not called out, but it's required. So we're going to be using this, and it's not supported, even if it's required. So we're using this moment in time to create that brief. And again, very, very grateful to our friends at A&D who are leading that charge, because this is their domain. And, we're just, thank you, Carly. Oh, I do want to note our A&D is a long-standing friend of Gravity. If you remember, they were our co-SMEs back in food insecurity. I was one of the subject matter experts, and there were some more folks, and it was the Academy of Nutrition and Dietetics in 2019. So they've been involved in Gravity for a very, very long time. Next slide. And then many of you on the call and many in this work were additional SMEs. We kept on bringing in more people at that time. This is, again, not unchanged. And again, I know a lot of our implementation entities care deeply about this. We are going to be recommending guidance on consistency of using certain modifiers once these concepts are created. The great thing about the new HCPCS is that they will allow us to leverage modifiers, not to define the thing, I've said this before, but to define facets of the thing, right? So final mile delivery, or cultural modifications, or mechanical modifications. Right, so we, again, are not leaning too far into that right now, because that's just implementation. Those modifiers already exist. So once the HCPCS concept is developed, we can easily reconvene and define that. But that is something that we know is going to be possible, and we're really excited about that. Hi, Lucy. Yes.
Final mile, frontier. To me, those are complete opposites. So could you explain what this means? I mean, frontier is, what does this mean?
Okay, no, okay. I don't know if they're completely opposites. That's why I was stumbling, but I'm going to tell you what. So we are trying to represent a base concept with a common value, right? What we recognize is that when you are sending groceries to, Homer, Alaska, when you are trying to
This
get
is a geographic modifier.
Yeah,
Okay.
it is. Well, it's a geographic, it's also a cost of delivering it to you.
I understand completely now. I
Okay,
mean,
great.
from a strategic planning point of view, frontier is the beginning and final mile is the end.
Oh,
So
I mean, frontier is in
I
like,
understand a
yeah,
geographic,
yes,
fine. All
great.
right.
Okay. I get why you were tripping, and my apologies. That makes sense. Okay. Thank you. Okay. Okay, this is just on the modifiers, and we're gonna be able to do this because we'll have these concepts. It's gonna be a brave new world, and our same leaders that drove this are the ones who will be able to create consensus on how to apply modifiers, like everyone on the advisory group and everyone in our work groups. They can, we can create that convention, because you'll be able then to analyze research and outcomes across different states, etc. Next slide. Okay. Things that we've done in general. So we had a walkthrough of the actual components of the HCPCS submission in the platform where you submit it. And it really caused us to think very clearly on a few different concepts. And this is what we spent our last couple of weeks on, whether there's enough evidence to differentiate like concepts from each other, right? Because one of the things we have to defend in MIRIS, which is the platform, is, does something like this exist? If so, how is it different? All the evidence of why, right? And you literally have to run down the list. Because the S5170 home delivered meals concept exists, this drove a ton of conversation on what we were going to be focusing on with the unique with the uniqueness of medically tailored meals, right? So because, again, what is and it caused some things that were kind of within the realm of what is sometimes being called MTM to be rolled down into the home delivered meals area. So there really was this what is unique, what can we defend, and leaning forward in that. And the same thing happened with medically tailored groceries. When we sat back and thought about the difference between a healthy grocery package in general to support a perinatal health program, right? And a healthy grocery package specifically geared toward entities with hypertension, right? We didn't know if we could defend that being so different, because tailoring for a unique person, we're going to get into that, we can defend that. So you'll see that we had conversations really thinking about the horizon of the MIRA submission and our, planning for success there. Next slide. And so I pulled all the comments and questions from Maris. And so we're not going to go through all the content here. There's a lot on the slides, but I wanted to bring you all with us because even within our group, we had to remind ourselves what the dietary guidelines say, right? Our group and Katie's laughing because she knows it's true, right? So it was like, let's review the US dietary guidelines 2020 to 2025, right? Because we do need guidelines to support our submissions. So just for a point of reassurance, the healthiness of what's represented here, perinatal, pre and post, para. So not just pre, not just post, para.
So I don't see perinatal here at every stage of life. Am I missing it because I'm reading too fast?
Oh, okay. I hear what you're saying. But lactate, yeah, I hear what you're saying. But again, I can't change this. This is the USDA guidelines.
Oh,
So
I'm sorry. Okay.
yeah, I mean, that's not why.
All right. This is from on high. Okay.
This is from on high. Yeah, with citations. So just because we knew we had to base our submission on guidelines and evidence, there's a lot of citations over the course of the next few slides. I just wanted to make sure everyone had some reference for what's in there, so I pulled the basic principles out. The basic principles are applied to different ages to have different specifications, but they roughly create our guidance on cup equivalents or servings or components across many of our, at least the actually all of them. And then once you get to the medically tailored meals element, the RDN's expert assessment takes the guidelines and uniquely crafts it for you. All hail RDNs. Wonderful. Okay, so the first principle is following a healthy dietary pattern at every stage of life. Again, not going to read through this, but once we get into the concepts, if you didn't have this, I didn't feel like you would understand what we're talking about. Next slide. The next principle which is important, again, like it's important to know this is supported in guidance from the USDA. Customize and enjoy nutrient-dense food and beverage choices to reflect personal preferences, cultural traditions, and budgetary considerations, right? Written into the dietary guidelines is that cultural component. We've been talking about it from the beginning. It's right there, right? Next slide. Then the third principle is focusing on meeting food group needs with nutrient-dense foods and beverages and staying within calorie limits. Again, this helps create it helps ground the understanding of why when we're talking about groceries and if we're aligning with the US dietary guidelines, the difference between a renal specified healthy grocery package aligned with the guidelines and the perinatal grocery package, we didn't know if it was sufficient enough to get two concepts, so we're going to start with one. Oh, hi, Jess. Fantastic. And again, that's like the modifier elements are not directly the focus of this work, but luckily all of you smart folks will figure out how to determine that. But roughly it's the extra cost of delivering it to remote locations, right? Okay, next slide. Getting to know Jess has been great. Hi, Jess. Another principle, because again, we care a lot about quality, and we've been talking about quality in our meetings, is you'll see this woven through, is the principle of limiting foods and beverages higher in added sugar, saturated fat, and sodium, and limiting alcoholic beverages. We don't include alcoholic beverages in any of our coding for food concepts. But again, the health of this kind of provision, so not just anything, like I'm giving you healthy groceries, I'm giving you produce to support the US dietary guidelines. That base understanding, which is different than most of us eat, is what infuses the concepts here, right? So, and you'll see that I just didn't want to go into the coding for food concepts without understanding that this is our evidentiary base, which is aspirational for lots of individuals, whether it be on sodium content or saturated fat content or produce and veg per day. Next slide. Okay, I think that was the last principle. Okay, the other thing I wanted to note just from an evidentiary-based perspective are the USDA food plans and costs. That's another thing that we've been wrestling with in our meetings is the USDA calculates food plan costs across 4 base budgets. again, this evidence is all there. It's all part of our repertoire. There's so many spreadsheets, one with every single food you could possibly produce, you could possibly imagine. And we've used this to ground our conversations. There's the thrifty food plan, the low-cost food plan, the moderate-cost food plan, the liberal food plan. And then these food plans have modifications for Alaska and Hawaii due to cost of delivery. And they're just base part of what USDA produces every cycle, right? The thrifty food plan represents food expenditures on a limited budget, and it's the base for SNAP. This is really important. But aligned with the thrifty food plan, there's lots of handy ratios we've used throughout our work, like servings per pound ratios, or other ratios. So beyond cost, the guidance of the thrifty food plan is pretty robust, and the USDA gives a lot of material we've used throughout our work. There's a low-cost food plan, moderate food plan, a liberal food plan, then represent the second to bottom quartile, the second to top quartile, or the final quartile, right? So those are the differing expected budgets that the USDA produces, and they're used from everything. The thrifty food plan is SNAP, but the low-cost, moderate-cost, and liberal food plan are used for everything from child support allocations to, meals per day allocations for federal entities or defense workers. This is like the base of a lot of the calculations of cost that happen in the ecosystem. So you're going to see us doing some cost calculations and considerations when we go. Oh, yes. And Bill, that's, again, this is just a base, and you can see actually Hi, Bill. Bill was part of the food insecurity work a long time ago. Wonderful. Okay, I think Bill, first of all, thank you for email and thank you for the comment. And I think that you'll feel, and I hope you see that concept's represented in the concepts to come. Next slide. Okay, that was just like the history, right? That's what's grounding our work, because we wanted to point to some kind of guidance on what is best. And so in addition to the evidence for each of these things, which is also what we're working on, the base guidelines across the USDA guidelines, US dietary guidelines, certain specific program guidelines like WIC and the FDA standards of identity. These are all things that are woven through our concepts, just like a massive evidentiary base with the hope to create some kind of consistency of provision and consistency of quality, right? If we're creating a national HCPC concept, we really want to make sure there's some, rough equivalency across different provisions, and the standards help us do that. Okay, produce prescription. Next slide. Okay, so, and the reason why this is bolded is kind of the final thing that we are working on right now is really in the realm of how much, right? And we would love to have your insight on this, right? So our last meeting was just yesterday, and we have some base concepts pretty like formalized, right? So it's produce provision equaling approximately, like bookmark that, cups and or cup equivalents. And this is all federal. This is all grounded language in each of the guidelines I just mentioned, which is why I wanted to preface you all with that. Cups and or cup equivalents per day for one person aligned with national whole parenthetical, fresh, canned, frozen, and dried produce guidelines. Excludes juices in all forms. The standard of reference is WIC, fruit and vegetable criteria, and aligned FDA standards of identity. All of this is aligned with federal regulation, like all kinds of things to point to. And so we have what we've settled on regarding provision variations is we don't know again how much, but there's tons of evidence again on the cost of fruits and vegetables in the ecosystem. So again, there's spreadsheets that the USDA produces at regular cycles. We don't actually have to say the ratio. We can just say use the current average ratio for fruits and vegetables for this year, right? Bing! Like right now, I think it was $1.07. That was what we were using yesterday. Right. So because there's all direct provision and like vouchers or prepaid cards, we wanted to note that for right now, if you're using a voucher value, use that USDA ratio. And then we also wanted to allow for the provisions that just base on pounds, because if you're doing like food bank provision, a lot of the food is delivered in pounds. We wanted to include them in this as well. So we have the biggest question here. Like the what is WIC aligned except no juice, right? The guidelines are WIC plus the FDA standards of identity, which have clear criteria on sodium and sugars and all of those different things. The variation cost component is whatever is the current USDA guidance on the average cost of fruits and vegetables for your region, and knowing again that there's always that Alaska and Hawaii variant, right? And then always the current pound to ratio, pounds ratio, the ratio of cup equivalents to pounds. So that is, so the biggest thing, we just want to hear like your thoughts on the amount, right? So if you were providing the whole amount for like a person, it'd be 5 equivalents per day-ish, right? But we were wary of doing that because what we are leaning into, and I hope I see some of the subject matter experts on the call, is that we've been having conversations about what is the dose at which you see a benefit, right? We don't want to create a standard that exceeds the dose where the lowest benefit is. It's like the same, that would mean for me, like I was mandating you take a higher dose of your hypertension medication than actually meets requirements. So right now we're really leaning into what is the unit, knowing that like some evidence says that you can achieve some evidence that might need to be brought up to federal, like to normal cost requirements for 2024. Note that you have a benefit of $40 per month. You know, this is some vouchers for veggies data we were listening to yesterday. So any thoughts? Knowing that 2.5 can always be added to multiplied to equal 5. So we, Michelle, I think we did have that conversation. So far, what they're wanting to do is just aim for the adult standard. We keep on bringing up whether to modify it for younger individuals, and we haven't agreed that that's good or required. So that's been raised, but it hasn't filtered to the top. So it's based on the standard for the, unfortunately, the standard for the US dietary guidelines, which is the 18 to X-year-old male. For right now, understanding that that's more than some individuals might need, but it is a base. Any other thoughts? Well, if no thoughts, just know your produce prescription team. Is anyone here from the produce prescription team? I hope this represents what we've been talking about. I think hi, Jess.
I saw Alex and Jess and maybe a couple others.
I
So
know,
yeah.
I'm gonna call on you. Jess is one of our amazing friends who's been working on like ratios and everything. Jess, thoughts? And I see Alex. I can now, yeah.
I was double muted. I'm sorry.
Hi.
Yeah, I think this captures it pretty well. I still am curious about where we get input from, for example, a food economist through Gravity Project on the final selection of these standards.
You mean besides using the calculated ratio? So first, we have a couple of these with food economists. We have Brent reaching out. I have my contact at USDA,
Awesome.
who's a food economist. And we are leveraging everything on the calculations of food economists from USDA cool. Because of those ratios, right? So the good thing is their brilliance is baked in by design. Because I know a food economist is what creates the 1.07.
Right, exactly. Just to check our assumptions, right?
Oh, I know. And I want to thank you actually for driving that early. And then you triggered my nerdy deep dive. And then this is where we are. So we are.
I guess the one other thing to highlight for folks is I was going to lift up that, aligning with these USDA standards also ensures that there's some routine update alignment with those inherent regulatory required updates that happen with all those food plans and so forth.
Exactly. When you point to the standard rather than like a number, you can just say align with whatever USDA says is the average for this period, right? As opposed to a stagnant point. Thank you. Okay, and then Alex, and I see Bill's question. Any other thoughts?
Yeah, so I just wanted, it's Alex Goldman from Vouchers for
Hi.
Veggies. Hey, I
Oh, I
just
just
wanted to
mentioned you. I know, here I am. I just called you out. Here, hi.
Hey. I just wanted to also mention just some of the experience that we've been having, and again, I personally hate to see this driving any recommendations that we make, but some of the experiences that we've been having with our own work with health plans is that there is a lot of financial risk aversity among health plans
Yes.
in adopting all of the social determinants of health community supports. At least that's been my experience. We're based in San Francisco, California, working under CalAIM. So I think my team has produced a lot of the research that does support $40 as an effective amount. I think you would be hard pressed to find anyone on my team who wouldn't also support a much higher amount, especially we're in one of the highest cost of living areas in the whole country.
Yeah.
That said, our experience working with some health plans in our area is that yes, there is a lot of financial risk aversity, and we don't want to create a standard that makes it so that health plans don't want to adopt produce prescriptions as a food support when they're looking at their full suite of options in the MSF&N space. So that was another consideration. And again, I hate that is even something that we
No.
have to consider.
But I just want to note that the reason why we're considering it partly is because of that lowest dose that has a benefit effect, right? It's not, we're only considering it because because it's appropriate as a therapeutic dose. Like I'd never allow a medication to go lower than benefited the person, right? So if the evidence says that a dose that small has effect, right? We want to support it. And so you just did a brilliant job of representing the conversations we were having yesterday, which is partly why we have the 2.5 and 5 here, is that 2.5 more closely aligns with the lowest bar for evidence. And the 5 is like a very significant benefit that has different outputs, but that's where we are right now. But just know if you have a 2.5, you can always do 2 and create a 5, or you can do 3 and have that cancer preventative diet we were talking about like 5 meetings ago. Anyway, thank you, Alex. So
Yeah, thank you.
yeah, and what we can do is like again the research again. Hillary Seligman was one of my early friends in 2019 on the food insecurity work. So just note that that the research there is pretty profound. So we want to make sure that we don't disable doses that have a beneficial effect. Okay, any other thoughts?
There was something in the chat. I think two
Oh
things.
yes, we see. Correct, and that depends on the program. And one of the things that Katie, you brought this up, and so because this is just produce, we don't have that full diet requirement, right? So with groceries, we have to be super careful, but with produce, it's always supplemental because there's other things that aren't met in the diet. But Michelle, we did, and I think Katie, did I do that justice, that comment?
Yep.
And then we did our friends talk to their lawyer friends, all hail our friends at Chipley. And that was an adequate interpretation of the guidance there. So just noting, and so within groceries, we talk about that a lot, or medically tailored meals, because you are trying to meet the dietary, that actually doesn't really apply. But with groceries, you are trying to you could meet a comprehensive diet plan. But we did talk about that. Hillary is a fearless leader. I love Hillary. She's a hero. And then Bill, we are talking about servings per day times per week, so that we are building it off a per day understanding, even though we're not going to, it's all going to be rolled up into I think we're at weekly, yes. Okay. Lucy?
Yeah, this may sound crazy, but I'm sure, Sarah, that some of your patients actually grow their own food.
Correct.
So if a provider discovers that someone who purports to have food insecurity is growing something, is that material for amounts
No,
here?
yeah, remember, these are not just prescribed for food insecurity. So that's important to note, is that and I don't think that would, and this happens all the time. Like I live in Vermont and people are witchy and do their own things and they take all kinds of supplements and
Right.
yeah, I don't think it would, because people, but I appreciate that. But number one, this is not just a food insecurity prescription, right? This is like a hypertension prescription. It's a heart failure prescription. It's a Hillary Seligman, Dr. Cervetti's leading visionary in the provision of vegetables for A1C control and diabetes, like literally like forefront, bleeding edge of research in food as medicine there. So I don't think that applies, but maybe Smeeze help me. Okay.
Yes, I would
There's a
say,
lot.
oh, sorry, to that point, yes, that is accurate. The other thing is that we talk about in these groups a lot, Medicaid, whereas lots of this is being paid for, is the payer of last resort. But just because someone is getting, say, SNAP, formerly known as food stamps, or CalFresh in California, doesn't mean that they wouldn't also be able to get a produce prescription, because obviously by the fact that that person has SNAP but still has diabetes means that they are not necessarily getting the intake of fruits and vegetables they need to meet their health needs.
Go team. And that's partly why the guidelines are different. It's not just an allocation of anything, it's an allocation of specific food for specific purposes, right? Okay, there was a very long comment. I'm going to capture that comment and probably respond to an email because I want to support you in an answer. And I don't know if I can do it now. Except for the fact that we are, unless Katie, you want to try to go
I
for
can
that?
get to piece of this pretty quickly, which is just Sandy, great question and point. And I will say not in this first phase of work groups, so
I know.
medically sourced meals, groceries, and produce prescriptions are we addressing this, but actually in a second phase work groups to launch come the new year in 2025. One of the work groups is likely going to be talking about cooking equipment
Mhm.
and the provision of cooking equipment, which is something that is paid for in Massachusetts. So certainly a piece of this, just not up for current discussion as of this moment. And I think that's the primary part of this question, but I'll keep reading it and happy to circle back if that's not
No.
a comment.
That's also part of the New York waiver that we included in gravity terminology to support, kitchenware, provision of kitchenware, incoming SNOMED CT concept. Just say, yay, kitchenware, even the concept of kitchenware, and the fact that someone was just like, yes, that's great. I had to work long and hard to find a definition for kitchenware. All right, coming soon. Wonderful.
And then we're gonna get into gas being a toxin in poorly ventilated
We
spaces.
already did that with utility insecurity. Remember? We had our.
I didn't remember, otherwise you wouldn't say it,
Sorry.
okay.
We did. We talked about it. Unsafe heating methods and unsafe cooking methods. We did.
Well, but there's certainly overlap here, so.
There is, yes. Thank
Okay,
you.
next
Bye,
year.
Michelle. I'm sorry because we're about to get into groceries and meals next. Okay, next slide. I do want to make sure we get through because okay. So just I already mentioned this, but the produce prescription references are the dietary guidelines, the WIC fruit and vegetable regulatory requirements. I put the regulatory guidance in on the slide, and the FDA standards of identity. So if anybody wants to go super nerdy, you can find all of these things, go directly to the regulation that specifies all these requirements. By aligning with it, we definitely have a case of consistency across and support for our HICPIC concept. Okay. Whew, yes, they are. Okay, thank you, Denise, longtime friend. Next slide. I do want to try to get through. Okay, this is my, Katie, you didn't see this. I was like, doot, doot, groceries. Because the ellipses there and the air quotes are going to be explained in a second. Next slide. All right, so where we are, and this, I'm going to remind you all that what happened is when we started to think about the what, and if we're grounding in the guidelines and how healthy that is, right? How, it's not just any box of food. It is an intentional box of food, supporting food as medicine, aligned with the dietary guidelines, limited saturated fats, limited sugars, right? Here. We realized that we didn't know if we had enough evidence to do two different concepts. That's not to say that the RDN isn't participating as well, and we're going to be addressing that through Carly's brief and A&D. But this is our working concept for groceries. And the reason why I have it in ellipses is originally we had conceptualized there might be two grocery components, medically tailored and medically supportive. And we talked at great length at our last groceries meeting on the different ways this is operationalized, whether it's for specific qualifying conditions, whether it's just pantry stocking along healthy dietary guidelines, whether it's for specific high risk groups, and that's where our perinatal community comes in. And so what we're working on right now is this concept, which is, then there's some things to be determined, but shelf stable products, produce and other perishables if able, and we still have to figure out like how to work on that. Designed to meet at least a third of the comprehensive recommended intake per the U.S. dietary guidelines for one person. And again, this is important because Michelle, even though she's not here, that relates to that not the full food for a person criteria, right? Just like with produce, we're starting with 1/3, and it can be multiplied to 2/3 if the program allows, right? It can be 1 unit times 2. We are stating that it includes population guidance for limiting sugars, saturated fats, and sodium. That's part of it's baked in by design. So it's not just anything on the shelf, it's like provision of healthy foods. And then necessarily includes alcoholic beverages, and we just wanted to note if appropriate, anything, and Bill, this relates to what you were saying. The guidelines are modified to meet disease-specific requirements, and we're going to try to represent that in a modifier, right? So again, referencing the U.S. dietary guidelines and the FDA standards of identity, modifier to represent the addition of perishables. This is what we're working through right now. One person, which is based, it's based on the base of the dietary guidelines. And then we are trying to work on what that ratio would be for the voucher conversion. With produce, it was very straightforward because of all this calculations that USDA does on fruits and vegetables alone. Yes, but that's where, if appropriate, U.S. dietary guidelines are modified to meet disease-specific requirements. That was the statement there to support what you just said, Jess, I hope, right? It's like guidelines are guidelines, but if you are doing a renal diet, your sodium requirements drop significantly, right? If you're doing a celiac bag, there's certainly foods that you cannot include, right? So hope, and we can work on the wording there, but that was, ooh. Did we just lose the slides? I think. Hamali, did we lose is she still here?
Molly joined again.
Okay. Oh, we lost Hamali, and then we lost her slides, and she's coming back.
I thought, I was not sure. I will share it then.
Are you okay?
Yeah, can you hear me now?
Yes, we can hear you now.
Yeah, I think I lost internet for a second.
Okay, I know, and you're not even in Vermont. So no worries. Okay, if we go back one slide, I just want to stay here for a second on the grocery provision. Okay, so this is where we are, right? Any thoughts on this? Again, this is fairly straightforward, and again, it gets operationalized across with diseases, across like disease of a specific criteria, across high-risk populations. And again, we're going to be trying to represent modifications to it in a modifier, right? So like if it's been adapted to be a celiac diet, or if it's been adapted to do everything, we're going to try to represent that elsewhere, because we didn't, in our initial assessment, have sufficient evidence to raise it up to 2 different concepts. Oh, and then what I was talking about before the slides disappeared, I was like, where was I? We're working on the ratio for conversion into a prepaid card, or because of the difference of the meal plans, and the thriftiness of the thrifty meal plan means it might not be the best like cost ratio. And so that's just coming, we're working on that in that group. It'll have that same guidance like the produce prescription did, though, which is like pointing to a meal plan of reference if you're trying to calculate what 1/3 of the food would be. Awesome. Okay, not as much conversation as produce. Just wait till we get to MTM. Next slide. Again, because these are tidy, these will be posted on Tuesday for reflection dissemination. Send us your comments. We want to include them. We have more meetings next week. So we're going to keep on tweaking those subtle little things. But again, as I mentioned, we might not be able to sufficiently defend a tailored and healthy grocery provision as unique concepts, right? Because if we're following the guidelines, we already have a pretty robust bag. And then, as I mentioned, we're starting with healthy groceries first to support, along with the US dietary guidelines, again, with a modifier suggested to represent disease-specific modifications. Okay, next slide. We're going to go into MTM now. Again, aligned with US dietary guidelines and the FDA standards of identity. Next slide. Again, what I hope you feel in this is a desire to create a standard that's consistent across the whole country and multiple entities, so we can start like having the whole intent was to create some kind of consistency in measurement and across different states for research and for provision and for clarity. And so you can see, I hope you see this in each of the different concepts. Okay, healthy type of meals. Ooh, we've done a lot, Katie. I'm starting to feel, I'm like, woo. Okay, so the big push here is that we settled on a path forward. Again, we already know, and again, Fiona was on this call. Is she still here? I think she might have left. I just want to note our Meals on Wheels friend. Yes, she left. Okay, too bad. Okay, I wanted to highlight centering her. So we are doubling down in our differentiation of medically tailored meals from home delivered meals by binding it to the RDN's assessment, knowing that you can't write the labor into the code, but we are saying this is unique, and you'll see it on the next slide. Because this medically tailored meal is no, I know too much. I've talked to too many RDNs to ever think nutrition care is simple. So the core point again, this is food is medicine supports here is this medically tailored meal is part of a therapeutic diet plan. It's not just a meal. It is literally part of a plan to support a person with specific conditions in wellness, right? And so this is the case we're making for how it's going to be differentiated home delivered meals with, like, for instance, there are many entities, and this is why I wanted Meals on Wheels on the call, but they're not here anymore. Like there's like small little modifications that you can make to have like lower salt, and that's like the renal diet. That will likely stay in the realm of S5170, right? Because we're gonna have a new concept that is specifically based on a holistic assessment. We did center our friends at Meals on Wheels last meeting. We had this like moment where like, does this make sense to you? Hi, Lucy. Yes.
Yeah, thank you, Bill Swan, for expressing my feelings this whole meeting. But this slide, Sarah, this slide seems really important to me. My whole professional life, I have thought of food as a social determinant of health, like housing or transportation or any number of
okay.
things. And now here this
Yeah.
group is now trying to say,
Yes.
this is a health determinant,
Correct.
not a social determinant.
No question. It's
So-
prescribed as part of a
So
plan.
I don't know whether, I mean, this is going to sound crazy, but is this out of scope
Oh, no.
for gravity? Because we don't talk about health determinants like genetics. We talk about social determinants. And here we are talking about food as a health determinant. So this is a very stratospheric thought, and I'm sorry to be wasting everybody's time with it, but
No.
it seems really profound here that we are migrating from thinking about food as a social determinant to thinking about food as a health determinant, like medicine, which we do not address whatsoever.
Thank you for that thought. It is not
Okay.
out of scope because there's a Venn diagram that sits in the middle, right? It's not this or that, right? And we
Okay,
do
as long as you're clear about
100%.
this, and
I'm
I'm
100%
sure that
clear.
all the
Okay.
SMEs on this call are clear about this,
Mhm.
but I'm just
Yeah.
saying, as an outsider, learning a lot
Yeah.
here.
Look at Jess.
This
Yeah.
is really interesting.
Access to a therapeutic diet plan is a social determinant. Thank you, Jess, for that. And then Lucy, just know, medically tailored meals was first defined in gravity food insecurity work in 2019, and our first identification that we needed a HCPC code to represent it came out of that work. Like this, I've been having this conversation with these folks since 2019.
So I was there and,
I
okay,
know. Yeah.
so
So the Venn diagram supports it.
thank you.
Jessica
Okay,
supports it. Yes. Perfect. And then Mike is not just because there's significant differences in the what, not just the assessment, right? And so you're going to see that on the next page. So Mike, I just want to go back to what you said right there. So it's not just home delivered meals plus an RDN assessment. It is the actual substance of the meal, which is different because of that assessment. And I think we'll show you, that's nice. Exactly. Okay, yes, but just know end care deliverers and providers of this service feel like it's different enough and that it warrants an additional code, Mike. We got you. Okay, next slide. So we can get into the what. It's nice. Hi, Mike. It's nice to see you here. Okay. Okay, there were some final changes here. And so I just want to note that the things that are in bold and italics, like there were some last minute thoughts on, but there's a lot of like solid agreement here. So I'm going to walk through it. And again, the wording is getting tweaked, 1/3 of the recommended dietary intake per day for one person is that way because of this. It's because depending on the needs of the person, it's not just 3 meals a day. If they have gastroparesis, if they have certain metabolic conditions, if they have, if they're just older and want to eat like small, frequent meals through the day, we can't talk about meals. We had to distance ourselves from meals and really think about like how nutrition is delivered to a person to cover 1/3 of the needs of the person for the day. Sometimes that third is 2 meals. Sometimes it's 1 meal and a snack, right? So medically tailored meals takes all of that into consideration, guided by the assessment of the RD. And this is like legit proof. You can look at all of the guidelines that are based, those like underwrite MTM. And it is, so it's 1/3 of the recommended dietary intake per day for one person for a reason. And it's comprised of natural whole, that's in discussion as defined by the FDA because we wanted to be careful. This is not, like I said this, yes, I was trying to remember what I said last, because like, it's not like, marathon goo that you squirt into your mouth, right? This is a whole meal with nutritious foods. We are weighing on, like each of these concepts has FDA citations, the things that are in italics. So we just need to figure out what we want to say there. Because when you say natural, it means something for the FDA. And when you say whole, it means something for the FDA. So more to come on that. The next component is based on a registered dietitian, RDNs, and then there's a little star assessment of the person's nutritional needs. And I'm going to stop there. Actually, I should just say based on the RDN dietitian nutritionist assessment, asterisk stop. It's that way because we are binding it, as you can in some instances, with a HCPC concepts to that labor, even if we're not saying paying for the labor in this code. And there's an asterisk there because when you look at the federal regulations to support the delivery of medical nutrition therapy, which is the labor codes that RDNs use, there is a call out for other nutrition professionals in the Social Security Act 1861 VB, which I just read today because, the things you have to do to support the concept. So more to come on whether we include that nutrition professional in the concept as well, because it's built into the Social Security Act, we might, right? That's why it's asterisked. And then the next section is assessment of the person's nutritional needs, both energy and micronutrient. We had a lot of parentheticals originally. We pulled them all out. So far, this is the only one that's staying, right? And that's important because it's not just the nutrient needs, it's the energy needs. So what a 250-pound man needs is different than what a 95-pound person needs, right? So the RDN creates that, completes the assessment, has energy needs and micronutrient needs as part of what they understand, and recommends a diet plan accordingly. And then lastly, and importantly, it has disease-specific evidence-based tailoring as part of that therapeutic diet plan, right? This is like what medically tailored meals is. It's like a therapeutic diet to support specific conditions and specific purposes. incredibly supported by the evidence. Again, it makes me think about Seth Berkowitz and his original MTM discharge CHF paper in like 2020. I don't remember when that came out, but I was like, it's there, it's brilliant. Talking about how medically tailored meals post-discharge prevented readmissions because it was so fundamental as a part of a therapeutic plan. You can get food through home delivered meals if you meet certain conditions. So there's different meals requirements that are operational. Happy to show you all of the different ways to get meals. There's meals provided through the Older Adults American Act. There's meals through other entities and other programs. But this is specifically for conditions, this one. Like the other S5170 that, you know, Meals on Wheels, like anybody who qualifies for that, I sign them up. If you're living in a congregate facility, if you're an older adult at home, I just sign everybody up for MTM in my FQHC. This, okay. Whew. Standards of reference are the US dietary guidelines, of course, but again, you leave that really quickly once you have the RDN involved. So the energy, micronutrient, and disease modifications are driven by that RDN's assessment. Great. Okay. This is, again, the natural whole is to be determined. The RDN and inclusion of the other nutrition professionals supported by MNT regulation is to be determined, but this is pretty much where we are. I mean, there might be some small modifications. Any thoughts? I think, you know, it's 517. No, I think it feels pretty solid to me. This is like the first time when I saw it up there for the slides, I was like, this is what we've been saying, and it looks pretty great, right? And then we have the case, because this is so distinct. This is not the same thing as S5170, not at all. It is what the evidence supports. It's what's happening out there. And then this drives, and all the evidence of specifically medically tailored meals, like the Seth Berkowitz study I just mentioned, are the why this is necessary and why it's different. Great. Oh, Denise, yay. RDNs, yay for RDNs. This has been an RDN appreciation effort. Another nutrition professional, I should say. Because much like social work in community-based organizations, there's lots of collaboration between licensed like RDNs and other professionals who are providing, you know, extended services. And so one of the things we talked very carefully about, like the how this happens is, you know, there's a lot of flexibility, but that's outside of the scope of this concept. Oh, no, so that's not, so Julian, the eligible conditions is operational. That's not part of this concept. And so there will be, yeah, I love that you already answered, Julian. Because it could be, this concept is, it's just like we don't say what you can prescribe certain things for, like in every, like there's FDA regulations, and then there's others, but we don't for medicines, but for this, it's going to be left up to operational definitions. And there's a ton, as you know, with your new job. And happy to, you know, we have our, you know, that survey that we did, you, Katie, and Kristen did on all the operational. Oh, I know, Jess, I'm so sorry. I did it some places. I did not correct C to T all the places. My apologies.
Microsoft Word doesn't help us in this
No,
space, so
I know.
you're
I
great.
really tried. I want to let you know. I went like, and the team can attest, because I was like, it was a big week and I was doing a lot of editing. So yes, thank you. And here's to all, again, this concept doesn't require, like, for instance, like Lucy, even though we're saying it's evidence-based tailoring as part of the therapeutic diet plan, like if you have pre-diabetes, if you have like pre-hypertension, right? If you have, you know, protein in your urine, right? What we want, imagine is a future where this can be prescribed for an unending list of important purposes, right? Even though there's a few core diagnoses that are usually covered right now. We also are trying to support enough conditions that, and this is why Carly's writing the brief, that what is currently covered by Medicare policy is expanded, because it's not the work that drives this is not well compensated for. So that's why Carly's making the brief. Jeez. Okay. Okay. Next slide. I think again, our major job today, and again, I'm sorry, we've used the whole time on coding for food. My apologies. For anyone who was here for classification, I'm so sorry. We just spent a lot of time talking about coding for food, but it's really important because the next time we come to you, it's with a vote. And we had a lot of work happened over the last couple of weeks, and we wanted to bring it to you. I'm going to quickly just show a couple things regarding classification before we close, if that's okay. We have 9 minutes. We good? I see you, Owen. Patient. Thank you to all of our subject matter experts. You'll see copies of each of these on the for the coding for food on Tuesday. I hope you can see how much work our work groups have done. Bravo to all of the SMEs who are driving those 3 work groups. Incredible work. I mean, it's just been an amazing month. Okay, onward. Amen to the big week. I know. I just keep on, yeah. Next slide. Okay, program enhancements. Next slide. Just noting the 3 activities we're working on regarding enhancements. Again, there's new things, and then there's enhancements to existing things. Coding for food is firmly an enhancement of food insecurity, Lucy, because we raised all these concepts as critical interventions that could support food insecurity, even if they were qualifying other conditions. And so that's why this work was identified as part of that process. So we have program term enhancement, program classification, and program documentation. More, next slide. I want to get to a couple quick slides. Next slide. Program classification, pathway. No significant new. I want you to download the master on Tuesday. So I'm going to move through these slides. Next slide. There's a new section. This is familiar to you all by now, how we're organizing it, we're defining the program type grouper significantly with its like super types. And then Gravity comes in specific programs. In many of the future domains, Gravity doesn't have material there. So we're doing health now. I'm helpful in health because I'm an FQHC, longtime ACO, health service area integrator, but Gravity doesn't have concepts for all of those. So we're supporting that work in classification, but Gravity won't have a ton there to map to. But luckily our other classifications, such as our friends at T11, have a ton. So there'll be the high level grouper. And then maybe this is where 2-in-1 HSIS comes in. Next slide. Ooh, before I move to the classification, when you download it on Tuesday, if you do, this is what we're thinking about, and we want you to think about it with us, whether groupers should be combined or split, whether groupers have the right names, whether we have missing groupers. Is there something that you do in your community that's critical that it does not have a concept? Next slide. All right, we're gonna quickly go to the classification. I think you have it pulled up. Can you if we can just go to it and quickly share the new section of social connection and engagement. There we go. Okay, if we scroll down, nothing new there. You can see, please add all your comments, reflect. But down on the bottom, keep on going. It's a big classification. We've been doing a lot of work. All right, here we go. So just new now is we have our social connection engagement classification section. Our 2 super types are finding social groups and learning skills. Again, this is a combination of like education status, like high school, college, like any kind of community-based education, like learning skills. Or any of the social connection interventions will go here. I haven't done Gravity's work yet. There's a ton of terminology that I will plug in here by Tuesday, like as I mentioned. So it includes social connections and social engagement and any kind of skill development that doesn't fit into the achieving your high school degree, achieving your college degree, achieving your master's degree, classic educational milestone pathway. You'll see all this on Tuesday because I want to get you, if I can, quickly pivot you to the remaining slides. And again, coming to you master on Tuesday. We're meeting twice weekly with our classification SMEs to finish out things. And again, sorry to Himali to take us back because I really want to get to the next slide. Okay, next slide. Okay, classification, downloaded Tuesday. The SMEs are doing really great work. More to come there. I just wanted to let you all know a couple things. Oh, next slide. I'm sorry. I think this is I think I went the wrong way, or maybe keep on going. Next slide. I wanted to show you, quickly update you, as we've been mentioning, Gravity's partnering with the CDC to assess opportunities for enhancements across housing instability and homelessness. We're specifically leaning into better methods to support identification and documentation of homelessness aligned with federal policy McKinney-Vento. Everything we say here was part of our housing and homelessness domains in 2020, I think. So Gravity's first task was a housing instability and homelessness gap analysis across 3 core activities, standardized instruments, diagnoses, and interventions and programs. There's a lot of programs that came out of our classification work. Yes, Lucy?
What is McKinney-Vento?
It is
This
the
is
regulation.
Greek.
No, it's the regulation that defines homelessness policy and identification in the country. I literally have the regulation for you to point
Why
to.
is it called McKinney-Vento?
It's just an act. It's the guys, it's the people who initiated
Oh,
the.
it's the statute. It's the
Yeah.
Thank you.
Yeah. Yeah.
Thank you. All
Yeah.
right.
Yeah. But but it is McKinney-Vento. And so everything, and so there's been gaps. McKinney-Vento defines a couple core types of homelessness.
That's fine. I just needed to understand, what is this referring to? It's referring to legislation.
Oh,
Thank
yes,
you.
I'm sorry, federal policy. I tried to do that. Okay, anyway.
Thank you.
This is the third time I'm mentioning federal regulations and policies here in the coding in the program enhancements meeting. So there's soon to be on the Confluence is the assessment Gravity did of all of the alignment with HUD, McKinney-Vento that was part of our initial work in 2020. Opportunities, and so there's a little brief that I made for the purposes of the CDC and this work that will come on the Confluence shortly. And so now we're going to work on gap filling in the next section. So incredibly nerdy deep dive into HUD, housing homelessness regulation, that I did over the last month with friends at CDC. More to come there. Just as a reminder, though, every single thing we did with housing instability and homelessness was in partnership with experts at HUD. So all of our definitions align with HUD statutes and regulations and policies by design. So that's, a great comfort. Next slide. Okay. And then the next section's not new. So I'd rather in the last 2 minutes, if we go, this is always presented these before. So homework, if we can get to the homework section, it'd be great. Okay, community homework and next steps. Catch up if you need to. The classification, which I didn't put here, and I should have, my apologies, I didn't update the homework. We're going to get those slides from Coding for Food as deliverables on the Coding for Food Confluence page, not just the recording this time, so you can download them and spread them around, right? So the one pager on what is produce prescription, the one pager on what is the groceries concept, and the one pager on what is medically tailored meals, just the content on that slides. That will be on the in the Coding for Food Confluence page for your downloading on Tuesday. If you want to look at it, because we're heading into vote, I wanted to make it a little bit more tangible for you. So that's to come. The classification will be there as well. I hope to complete it Gravity homework by that time. Consensus voting occurs on November 21st. What a jam-packed meeting. And in the grand scope of a complicated week, it's really lovely to come and work on tangible, important things with you all. Like, so good. You guys are the best. And any other final thoughts before we call it the densest Coding for Food meeting we've had yet? But look how much we've done. Any other final thoughts?
Sarah, could you hang on for 1 second when everybody hangs up, please?
I can. I have a meeting at 5:30, believe it or
I
not.
know, it's only 1 second.
Got it. Okay. Bye, friends.